Hello, welcome to Pathogonia. This is Jay Huang. Today, in request of our subscriber Mia, we're going to talk about prostate tumors using Kurt's Notes. If you already haven't been to Kurt's Notes, check out his website. He's got invaluable notes across different organ systems. Without further ado, let's talk about prostate tumors. When we talk about prostate cancer, the most often cancer is acinar adenocarcinoma. And this has various patterns and typically without basal cells. Epidemiologically, it's the most common cancer in men and the second leading cause of cancer death in America. And its prevalence is strongly correlated with age. The older you are, there's a higher prevalence. And majority are multifocal, often with 2 to 3 separate tumors in each prostate. Location-wise, you want to look about generally prostate cancer is in the posterior or posterolateral peripheral gland. And just for your reference, thank you to Teach Me Anatomy. This is the peripheral zone, and this is the posterior portion, and this is the anterior. So prostate cancer is generally here. And early tumors are often asymptomatic, but locally advanced prostate cancer can mimic BPH with urinary symptoms. And the bone is very common site of Mets for prostate cancer. Morphology, you want to use every feature available. From low power, you want to look at architecture. Are there crowded small glands? Are there a linear row of atypical glands spanning the width of the core? Small glands on both sides of a benign gland? Haphazard infiltrated pattern where they don't respect their boundaries? Is there a confluent or cribriform glands and single cells? If you look for architectural atypia, you want to zoom in closer. Then you want to see, is the cytoplasmic amphiphilic? Are there sharp cookie cutter like luminal borders like the ones you see in DCIS? Are there blue tinged mucin, pink amorphous secretions, crystalloids? And then you look at the nuclear detail. Is there prominent nucleoli? Is there nuclear enlargement, hyperchromasia? Are there any mites, apoptotic bodies? And absent basal cell layer, you can highlight with IHC, as fibroblasts that are near the glands may mimic basal cells. Usually lack desmoplastic stroma, but when present, often associated with high-grade carcinoma. Now, there are benign mimickers of prostate cancer, and features that favor more benign glands are atrophic cytoplasm, merging with benign glands, corpora amylacia, inflammation, and lipofuscin. The last thing would clue you into seminal vesicle. There are features that, if you see it, it's malignant. However, these features are not always present in prostate cancer biopsies. If you do see it, great, but if you don't see it, there can still be cancer. These three things are glomerulations, which are cribriform formations attached only to one edge of the surrounding gland and kind of look like glomeruli of the kidney. Perineural invasion. Because benign glands may abut the nerve, you really want to see the tumor completely encircling the nerve. And mucinous fibroplasia, or for me, it helps me better understand it, collagenous micronodules. And these are dense nodules of collagen, which is made up of hyalinized mucin that's surrounded and encased by epithelium. Personally, for me, collagenous micronodules makes more sense to me. Specific variants, these have the same prognosis unless Dr. Schaberg otherwise mentions it. So you have the atrophic variant where you'll have cytoplasmic volume loss like atrophy. And like atrophy, often absent nuclear enlargement and nucleoli mimicking atrophy. However, luckily, conventional carcinoma is often present nearby, and it can be sporadic or after therapy, and often Gleason pattern 3, which we'll talk about later. You can have the pseudohyperplastic variant, which stimulates luminal cell hyperplasia with papillary infoldings, luminal undulations, and branching. You'll have round nuclei, not pseudostratified with prominent nucleoli, and it's often relatively pure and well circumscribed. Foamy gland variant, you'll have this abundant foamy xanthomatous cytoplasm and small pycnotic nuclei that can mimic Cowper's glands. It's usually combined with the usual type. Rare variants include microcystic variant, where you have large dilated round glands with flattened luminal cells, and it can mimic benign atrophy. You have your mucinous variant, where greater than or equal to 25% of the tumor has extracellular mucin pools, and it could only be diagnosed on prostatectomy. On biopsy, you want to say mucinous features, and you want to mentally subtract the mucin for grading. This is akin to mucinous carcinoma of the breast. You can only diagnose it on mastectomy, and you can only say with mucinous features on biopsy. Signet ring-like variant. Just the fact that there are vacuoles does not mean it's signet ring-like. Vacuoles can be seen in any grade of prostate cancer. But signet ring-like variant is where greater than or equal to 25% of tumor is composed of infiltrative single cells with large vacuoles that do not actually contain mucin. And it's Gleason pattern 5, and you also want to rule out GI metastasis. Sarcomatoid variant, carcinosarcoma, it's biphasic with both epithelial and mesenchymal differentiation. It has poor prognosis, and you can see various heterologous elements. Hypernephroid variant, you'll have sheets of cells with abundant clear cytoplasm, and it's Gleason pattern 4. pleomorphic giant cell variant, which is not pictured, you'll have giant, bizarre anaplastic cells with pleomorphic nuclei and without a spindle cell component, and has poor prognosis. Gleason grading. So it's from 1 through 5, and for our practical purposes, we just want to focus mostly on 3 to 5. But read 1 to 2 during your free time, but we do not diagnose it on biopsy. So Gleason grade 3, we do. You will have well-formed glands with lumina and a separate, discrete, non-fused, and you can have infiltration. Gleason grade 4 is a big game changer because it often disqualifies the patient from active surveillance. So you'll have ill-defined, poorly formed glands, gland fusion, cribriform glands. You can have hypernephroid glomerulations, and ductal adenocarcinoma without necrosis, which we'll talk about later. And then Gleason pattern 5, essentially you don't have glandular differentiation. You can have single cells, cords, solid sheets, and linear arrays. If you have cancer with comedal necrosis, then it's also Gleason grade 5 or comedal If you're unsure whether it's 3 or 4, get levels to help you out, especially if it's tangential sectioning. And if there's borderline morphology and or artifacts, first, you should show it to your colleague, and secondly, the lower grade should be favored. Gleason scoring. On biopsies, you want to mention the first number is the most common pattern, and then second most common pattern, which gives you the score. If there's only one pattern, then you add the same pattern twice. For instance, only Gleason grade 3, then 3 plus 3 is 6. There's no tertiary pattern assigned. If there's high-grade cancer, you should ignore the lower grade patterns if it's less than 5% of the area of the tumor. For instance, if 98% of the tumor is 4 and 2% is 3, then just ignore the 3 and call it 4 plus 4 is 8. High-grade tumor of any quantity, as long as it was identified at low to medium magnification, should be included. For instance, in a Gleason grade of 3, that's 98%, and 4 is 2%, you still mention 3 plus 4 is 7. And on needle biopsies with patterns 3, 4, and 5, you mentioned the primary pattern and the highest grade should be recorded. So tumors with Gleason score 3 plus 4 and a tertiary pattern 5 would be recorded as Gleason score 3 plus 5 is 8, even if there's very little 5 present. You will still mention that. Prostatectomies, you mentioned the most common and the second most common, and you get the score with the tertiary pattern if present. And in the setting of high-grade cancer, you should ignore the lower grade patterns if they occupy less than 5% of the area of the tumor, just like we had mentioned in the biopsy portion as well. And then your grade groups are based on the Gleason scores. So I'll leave this for your reference, but basically grade group 1 is less than or equal to 6. Grade group 2 is 3 plus 4 is 7. Grade group 3 is also 7, but it's 4 plus 3. Grade group 4 is 8. And grade group 5 is 9 to 10. Immunohistochemical stains. So markers that suggest prostatic origin are prostate-specific antigen, prostatic acid phosphatase, PSAP, and NKX3.1, as well as prostine. For our institution, we mainly use NKX3.1 because it is the most specific. And furthermore, PSA and PSAP can decrease after androgen deprivation therapy and are less specific. And it could also get some salivary gland tumors. There are markers that have limited utility due to poor sensitivity or specificity, including ERG, AR, AMICAR. Cancer versus benign glands. This is most useful for a confirmation of a small quantity of tumor. Basal cells are absent usually in invasive prostatic adenocarcinoma. And your stains for your basal cells, cytoplasmic will stain high molecular weight cytokeratins like CK56, and it'll stain nuclear basal cells with P63 or P40. AMICAR, otherwise known as P504S or racemase, is overexpressed often in glandular neoplasia of the prostate, around 90% with granular cytoplasmic staining. And it needs to be done in combination with basal markers, as high-grade PIN is often positive. ERG is specific for neoplastic prostate glands, but has a low sensitivity, so it doesn't have much value over AMICAR. Some pitfalls is loss of basal cells is not specific for cancer, and you can see this sometimes in benign mimics like atrophy, partial atrophy, and adenosis. And rare cases of adenocarcinoma can stain for basal markers, even though they don't have basal cells in a non-basal distribution. So you want to correlate with your H&E as well. And AMICAR expression can be seen in benign mimics such as atrophy, adenosis, and nephrogenic adenoma. So a common triple stain, one we use at our institution too, is this high molecular weight cytokeratin and P63. High molecular weight cytokeratin will stain the cytoplasm of the basal cells, and P63 will stain the nucleus of the basal cells. And AMICAR will have this red cytoplasmic staining in the neoplastic glands, but not in the benign glands. So here we see cancer because there's AMICAR staining and there's a loss of basal cells. Of note, you can see a faint pink blush sometimes in benign glands. Diagnosing limited cancer. So the major criteria for diagnosing prostate cancer, although not one single criteria is diagnostic, is 1, infiltrative growth, 2, absence of basal cells, 3, nuclear atypia, where you have these prominent nucleoli, nuclear enlargement. How many glands do you need? There's no fixed number, but many urologic pathologists like to see at least 3 glands with cytologic architectural features of cancer. If you don't have at least 3 glands, you can call it atypical small acinar proliferation, or ASAP, suspicious for cancer, or atypical gland suspicious for cancer. This is a descriptive term, not an entity. When you have a collection of small glands suspicious for cancer but lack definitive diagnostic features, or they're too small to be certain that they do not represent the edge of a benign lesion. Immunohistochemical patterns in ASAP, the basal cells may be missing in benign small glands. So IHC is primarily useful to disprove cancer, not to prove cancer. And if you even see rare basal cells in any of those suspicious looking small glands, that essentially excludes carcinoma for the entire population. And what's the follow-up? If you call it ASAP, is a repeat biopsy. So here, Dr. Schabberg shows us these just 4 glands without basal cell markers with some amicar staining. So he says this is potentially a borderline case, and if this is all you've had, it'd probably be safest to go ASAP, given how limited they are in the absence of prominent nucleoli. But some might call it 3+3. So in comparison from benign glands to prostatic acinar adenocarcinoma, benign glands will be big, regularly spaced glands with papillary infolding, small nuclei without nucleoli, abundant pale, clear apical cytoplasm, and corporal amylacia. Whereas in cancer, you'll have small, infiltrative, angulated glands with haphazard spacing, sharp luminal cookie cutter contours, large nuclei with prominent nucleoli, and frequent hyperchromasia, amphiphilia, eosinophilic, or blue mucin secretions. Biopsy reporting. For each biopsy specimen/location report, you want to mention the Gleason score and the grade group. You want to mention the fraction of cores with cancer, or if it's a TERP, the number of positive chips and total number of chips, and the linear extent of cancer in each core, the percentage and or length, whether there's perineural invasion or extraprostatic extension if present, and the percentage of pattern 4 should be recorded in cases with a Gleason score 7. With very limited pattern 4, the patient may still be eligible for active surveillance. So here's an example of the biopsy report. Prostatic adenocarcinoma, Gleason score 3+4 = 7, grade group 2, 10% pattern 4, involving 1 of 1 cores, 25% of tissue, and the tumor is or is not cribriform. Discontinuous cancer, this is controversial. Several studies have shown that the linear total end-to-end method correlates better with prostatectomy findings, as they often represent portions of the same tumor. However, there's no consensus, so consider reporting both for now. Extraprostatic extension, EPE. This is presence of tumor beyond the confines of the prostate gland, and it includes invading fat. But you don't need to have fat necessarily to call it EPE, because it can be when it involves loose connective tissue beyond the plane of the prostate, when it involves perineural spaces in the neurovascular bundles. And in the apex and base, EPE is determined when the tumor extends beyond the confines of the normal glandular prostate. And that can sometimes be hard to clearly define. Invasion of the urinary bladder neck. This is when the neoplastic glands involve the thick, intersecting smooth muscles of the bladder neck region in the absence of associated benign prostate tissues. Seminal vesicle involvement, where you have invasion of the muscular wall of seminal vesicle. It must be extraprostatic, and it's stage 3, according to the CAP synoptic. As just a warning, invasion of skeletal muscle does not count, as skeletal muscle is present in the anterior and apical parts of the prostate. Genetics, you'll most often have the TMPRSS2 ERG fusion, and other frequent mutations include TP53 and P10. Prostate cancer is one of the most heritable cancer types and is driven by a combination of SNPs, or single nucleotide polymorphisms, which each having relatively low risk, but they're often combined. And BRCA2 significantly increases your risk of prostate cancer as well. Treatment effect. It can show minimal or extensive changes in both benign and malignant glands, and use stains liberally, especially if they have a history of treatment, and do not grade if significant treatment effect, as it behaves better than grade would suggest. And radiation therapy, you might have benign glands that are atrophic, they have a basal cell immunophenotype, and may show marked radiation atypia. And for cancer, it's often inconspicuous with vacuolated cytoplasm and smudged inconspicuous nuclei or nucleoli. As you can see here, this benign gland with radiation atypia and tumor with treatment effect. And hormonal therapy, you'll have benign glands with diffuse atrophy and prominent basal cells. And for cancer, you'll have this clear cell nucleolus pore atrophic with vacuolated cytoplasm and inconspicuous nucleoli. Active surveillance. This is when patients are diagnosed with prostate cancer and just undergo regular follow-up with serum PSA tests and repeat biopsies to look for progression, rather than receiving treatment like a prostatectomy with curative intent. And the inclusion criteria include Gleason score less than or equal to 6, PSA less than 10, clinical stage less than T2A, where it involves 1/2 of one lobe or less, and especially if very low risk, where you have fewer than 3 prostate biopsy cores positive and all are less than or equal to 50%, and the PSA density is less than 0.15, and PNI is allowed. NCCN progression criteria, where it initiates transition to curative therapy, is when you have Gleason grade 4 or 5 on repeat biopsy, and prostate cancer found in a greater number of biopsies or greater extent of biopsies. You want to exclude this if there's any variant other than acinar, adenocarcinoma, ductal sarcomatoid, small cell, intraductal carcinoma. Will skip the active surveillance part. And active surveillance protocol is, as mentioned before, the serum PSA monitoring, digital rectal exam, repeat prostate biopsies in 6 to 12 months after initial, and yearly for up to 10 years. Intraductal tumors. This is non-invasive tumors growing within ducts. So you have your high-grade PIN or high-grade prostatic intraepithelial neoplasia. And this is a pre-invasive neoplastic proliferation, and it's often multifocal, and you'll have cytologic changes that look like cancer. You need to see especially prominent nucleoli. Other things you can see are nuclear enlargement, hyperchromasia, clumped chromatin, and although it's non-invasive, basal cells may be patchy and not confluent throughout the duct. And there are 4 main architectures, including tufting, micropapillary, cribriform, and flat, and often has the cytoplasmic amicar staining, but with retention of basal cells. And it's important because it's associated with subsequent detection of cancer. More high-grade PIN, a higher risk. Intraductal carcinoma, you need malignant epithelial cells filling large acini and prostatic ducts with preservation of basal cells, with either a solid or dense cribriform pattern where you have more glands than lumina, or a loose cribriform or micropapillary pattern with either marked nuclear atypia, where it's greater than 6 times the normal size, or cometonecrosis. And it can be seen in 2 scenarios. The more common is the intraductal spread of a high-grade invasive cancer, and also a distinct precursor lesion, separate from high-grade PIN with high risk of progression to cancer. And you often need IHC to diagnose this to see the basal cells surrounding it, and it can show loss of P10, which is rarely seen in high-grade PIN. And if you see this on biopsy, it's often treated with radical prostatectomy, as it's highly associated with cancer and multiple adverse factors, including high Gleason grade, high tumor volume, and sometimes repeat biopsy immediately. And as of now, it's controversial as to whether to incorporate into Gleason grading. If a lumen-spanning atypical lesion morphologically falls short of intraductal carcinoma, where you're not sure whether it's definitive intraductal carcinoma, you can call it atypical intraductal proliferation and recommend immediate repeat biopsy. Other tumors include ductal adenocarcinoma, which is a subtype of prostatic adenocarcinoma with tall columnar pseudostratified epithelium. One of my staff called it kind of looks like a tubular adenoma of the colon. The cytoplasm is usually amphiphilic. You'll have this elongate nuclei with more cytologic atypia than your acinar type. You have prominent nucleoli, coarse chromatin, and lots of mitotic figures, as well as frequent necrosis. You'll have architecturally a combination of papillary and cribriform in dilated glands. And the old name was endometrioid because it looks like endometrioid adenocarcinoma of the uterus. And it's typically around the urethra. And the immunohistochemical pattern is similar to your acinar adenocarcinoma, where you'll have no basal cells and amicar will be cytoplasmic positive. And it's more aggressive than your average acinar adenocarcinoma, and that's why it's graded as pattern 4. But if necrosis is present, then you'll grade it as 5. Basal cell carcinoma, malignant neoplasm composed of basal cells. And most cases show various proportions of like an adenoid cystic cribriform pattern with inspissated secretions and a basaloid pattern with small solid nests of basal cells. You'll have a desmoplastic stroma, which can have hyaline rim, and immunohistochemically, the basal cell markers usually label the outermost layers, sparing the luminal cells, while the luminal cells stain with CK7, and HER2 is overexpressed. Some cases with adenoid cystic morphology have MIB rearrangements like elsewhere. Your salivary gland adenoid cystic has that 6-9 MIB and FIB rearrangement. You'll have a normal PSA, and it can be aggressive, however. Urothelial carcinoma, this is most often secondarily involving the prostate from the bladder and or prostatic urethra. So determining which site the urothelial carcinoma is coming from is very important for staging. If it comes from the bladder, then it's going into the prostate stroma, that's T4. While if it's from the prostatic urethra, then it goes into the prostate stroma, that's T2. And it's morphologically similar to urothelial carcinoma of bladder, where you'll have these pleomorphic epithelioid cells with frequent squamous differentiation. And you'll have frequent spread of carcinoma in situ into the ducts. And invasion elicits a desmoplastic stroma. So this will be positive for P63, high molecular weight cytokeratin and GATA3, and negative for NKX3.1 and PSA. Squamous neoplasms are very rare and arise through either divergent differentiation of basal cells or transdifferentiation of usual adenocarcinoma following hormone therapy. Squamous cell carcinoma is just pure squamous morphology and has similar morphology IHC to squamous cell carcinoma elsewhere, and you want to distinguish it from secondary involvement from the bladder, urethral squamous cell carcinoma, or transitional cell carcinoma. Adenosquamous carcinoma has both glandular or an acinar and squamous morphology. Neuroendocrine tumors, you can have an adenocarcinoma with neuroendocrine cells, and that could be seen on IHC in many usual prostate cancers and does not seem to be clinically significant, so no need to stain routinely. But some cases can look eye-opening, where you can have pan-cell-like neuroendocrine differentiation with eosinophilic granules, and you can see similar changes in benign glands. You can have a well-differentiated neuroendocrine tumor. It's very rare, and you want to exclude adenocarcinoma with neuroendocrine differentiation. And small cell neuroendocrine carcinoma, morphologically identical to in the lung, where you'll have small cells with scant cytoplasm and stippled hyperchromatic nuclei. It may be admixed with acinar adenocarcinoma or pure, and you do not Gleason grade this, and it should stain with at least one neuroendocrine marker usually. And it may be TTF1 positive, and Ki67 is near 100% and very aggressive. Mesenchymal tumors, stump, like the ones you get in your gyne tract in the uterus, stromal tumor of uncertain malignant potential. You have tumor or specialized prostatic stroma, often present with urinary symptoms, and you can have several growth patterns. You can have a hypercellular stroma with scattered degenerative appearing cells admixed with benign glands. You can have a phalloides subtype with leaf-like branching, and you can also have myxoid, epithelioid, or hypercellular gland stroma, and expresses CD34 and PR, or progesterone, and has usually good prognosis. It may recur or progress. Stromal sarcoma, this is a malignant tumor of specialized prostatic stroma. It can have phalloides-like growth with malignant pleomorphic stroma or fascicular growth similar to a leiomyosarcoma, and expresses CD34 and PR as well, and it can behave aggressively. And Dr. Shaprock provides a nice table to differentiate some of these stromal cancers. Seminal vesicle, normal anatomy, these can look a little bit scary from low power and high power. You have complex papillary folds lined with pseudostratified tall columnar epithelium with microvesicular lipid-filled cytoplasm and prominent lipofuscin pigment, this golden brown refractile granules, which help distinguish it from prostate. You can have moderate to severe cytologic atypia with these hyperchromatic irregular nuclei. Some of them are called like monster nuclei, and it has coarse chromatin and prominent nucleoli, and it's slightly degenerative, and it stains with GATA3. The big key is looking for that brown pigment. Amyloidosis, this is amorphous eosinophilic fibrillar material that has linear or massive nodular subepithelial deposits. It's relatively common benign incidental finding and not associated with systemic amyloidosis. And if you can highlight it with Congo red with apple green birefringence. Adenocarcinoma, you always want to first consider secondary involvement, most commonly by prostatic acinar adenocarcinoma. Primary adenocarcinoma is rare. It has a variety of patterns, most often a papillary clear cell tumor, but it can be hobnail, and CK7 will be positive, CK20 will be more positive than negative, prostate markers will be negative, and often a poor prognosis. MEST, or mixed epithelial and stromal tumors. This is a biphasic tumor with stromal and benign epithelial components. It can be cystic to solid. You can have a cystadenoma, which has a lobular pattern. You can have branching lumens and cysts of various sizes. Fibroadenoma, which is a spindle cell component, is where the spindle cell component is more pronounced. Adenosarcoma, where the stroma is densely cellular and condenses around distorted gland spaces, like a phalloides tumor or adenosarcoma of the uterus. Mimics of cancer include basal cell hyperplasia, where you'll have proliferation of basal cells piling up and filling tubules and glands. It may form solid nests and appears very blue due to the crowded nuclei with scant cytoplasm, and it retains lobular architecture and smooth borders. Nuclei are very bland with very small nucleoli and basal cell markers very strongly positive. Central zone sampling, where you have your anatomic zone with characteristic complex architecture. So let's go back to our prostate gland anatomy. So here is our central zone right here. You can have prominent basal cell layer and low-grade cytology. You can have intraluminal bridges like Roman arches, and it can mimic high-grade pin. So in biopsies from the mid-base, have a higher threshold for high-grade pin and rule out normal anatomy. And then verumontanum mucosal gland hyperplasia. So I don't know what this was, but thank you to radiology assistant. This is where the verumontanum is. It's around the posterior portion of the prostatic urethra where it attaches to the ejaculatory duct. But you can have crowded glands near this region and often nearby urothelium, and corporal amylacia is often present, which can be a clue. Adenosis, or atypical adenomatous hyperplasia, you'll have a well-circumscribed, tightly packed, largely uniform glands. You have a lobular architecture with pale to clear cytoplasm. There's an admixture of small and larger glands, and occurs in the transition zone. So let's go back here. So it occurs in the transition zone here. Mostly seen in TURPs and prostatectomies. Some features that may be suggestive of carcinoma may be seen here, such as prominent nucleoli, crystalloids, mucin, but often merge with benign glands. And the principal differential diagnosis is Gleason grade 2 carcinoma, and this distinction requires IHC for basal cells. Basal cells may be decreased in adenosis. Demonstration of any basal cells indicates adenosis in this context, and carcinoma must lack basal cells completely. Atrophy. You can have simple atrophy, where you'll have these basophilic glands with scant cytoplasm, both apically and laterally, and they're normal caliber glands with normal spacing. Postatrophic hyperplasia, PAH, where you'll have tightly packed, very small, cytologically bland glands, very blue from low power, and usually clustered around a larger, dilated feeder duct, think terminal duct lobular unit of the breast. And bland nuclei without prominent nucleoli, and basal cells are present, and the stroma is often sclerotic. Partial atrophy, where it'll retain moderately abundant pale clear cytoplasm lateral to the nuclei with reduced apical cytoplasm. And it can produce pale glands that lack the blue appearance of atrophy. And it frequently merges with nearby atrophy. You'll have bland nucleoli without prominence, no infiltrative growth, an undulating luminal surface, and retained but possibly decreased basal cell marker. Cowper's glands, I mentioned before, can be a mimic for foamy cell variant of acinar adenocarcinoma. This is near the urethra, near the apex more specifically, and it has lobular architecture with central duct, abundant mucin-filled cytoplasm that's PASD positive. You should have no nuclear atypia or prominent nucleoli. The basal cell markers are positive, and frequently muscle-specific actin positive, unlike in prostate. And PSAP is negative, although PSA may be positive. Clear cell hyperplasia. You'll have big nodules of clear cells with cribriform pattern. You have smooth gland borders and lobular pattern. You have uniform bland nuclei without prominent nucleoli, and should have intact basal cell markers. And most often seen in the central zone on TURP in the setting of BPH. Again, their central zone right here. Sclerosing adenosis, you'll have dense spindled stroma with compressed and distorted epithelial elements. You have entrapped epithelium and ranges from small acini to cords and single cells. No cytologic atypia, and you can have surrounding hyaline sheath. Basal cells present with unique immunologic profile where the usual markers are positive like P63, high molecular weight cytokeratin, but it also expresses myeloepithelial markers like SMA and S100. And here are other mimics of cancer, including nephrogenic adenoma, malakoplakia, seminal vesicle, mesonephric hyperplasia, colonic mucosa, urothelial metaplasia, granulomatous prostatitis, signet ring lymphocytes, and periganglia because of the nucleoli. Well, if you made it this far with me, thank you so much. Again, thank you to Dr. Schaberg, and let's do a brief overview of what we went over. We talked about the most common type of cancer in prostate, acinar adenocarcinoma, often located in the posterior posterolateral peripheral gland, and majority are multifocal. You want to look architecture for crowding, linear row of atypical glands, haphazardness, confluence for cribriform glands, small glands on both sides of a benign gland, single cells. You want to look for a blue-tinged mucin as you look closer, amphiphilic cytoplasm, cookie cutter lumens, prominent nucleoli, nuclear enlargement, hyperchromasia, mites, apoptotic bodies, and often should have a basal cell layer. Although not present, if you do see it, it's cancer. And those include 1, glomerulations, 2, perineural invasion, 3, mucinous fibroplasia. There are variants that can mimic benign, and so it's important to know. You can have atrophic variant, pseudohyperplastic variant, foamy gland variant that can mimic Cowper's glands, microcystic variant that can mimic atrophy, mucinous colloid variant, signet ring-like variant, sarcomatoid variant, hypernephroid variant, and pleomorphic giant cell variant. We have Gleason grading, focus mainly on 3 to 5, and just know that 4 will often disqualify from active surveillance. We talked about Gleason scoring, where you talk about the most common pattern and the second most common pattern, and that gives you the score. And grade groups, and we talked about the relationship of grade groups to score. IHC, if you're concerned for metastasis, you can consider getting NKX3.1, which is the most specific. Cancer versus benign glands. So if you get a triple stain where you'll have a high molecular weight cytokeratin P63, that'll stain the basal cells. So the high molecular weight cytokeratin will stain the cytoplasm, and P63 will stain the nuclei. Amicar will stain the cytoplasm of the neoplastic glands. So cancer will have amicar positivity with the absence of basal cell markers. Diagnosing limited cancer, you want to look for infiltrated growth, absence of basal cells, and nuclear atypia. We would like to see at least 3 glands. If you don't, you can consider the diagnosis of ASAP, atypical small acinar proliferation, suspicious for cancer, or atypical gland suspicious for cancer. And this will often buy them a repeat biopsy. We talked about biopsy reporting, extraprostatic extension, where prostate tissue invades fat, but that's not only the case. It can involve loose connective tissue beyond the plane of the prostate, involving perineural spaces in the neurovascular bundles, and in the apex and base, when the tumor extends beyond the confines of the normal glandular prostate. Talked about treatment effect, where you should have a low threshold to order stains, where radiation therapy and hormonal therapy can cause changes. Talked about active surveillance, and we talked about intraductal tumors, where non-invasive tumors growing within ducts, including high-grade PIN, where you should see prominent nucleoli and amicar cytoplasmic staining, as well as retained basal cell layer. And intraductal carcinoma, where you'll have preservation of basal cells, and you can have a solid or dense cribriform pattern, where you have more glands than lumina, or a loose cribriform or micropapillary pattern with either marked nuclear atypia or chromatodecrosis. Other tumors include ductal adenocarcinoma, where you'll have this tall columnar pseudostratified epithelium. You'll have elongate nuclei, papillary cribriform architecture, typically in the periurethral region, more aggressive than your average acinar, and so graded as pattern 4. If there's necrosis, it's 5. Basal cell carcinoma, it's composed of basal cells. It can have an adenoid cystic cribriform pattern and a basaloid pattern. PSA is normal, but it can be aggressive. Urothelial carcinoma, most often secondarily involving the prostate. You want to make sure whether it arises from the bladder or the prostatic urethra, and it's GATA3 positive. Squamous neoplasms, very rare. You can have squamous cell carcinoma or adenosquamous carcinoma. Neuroendocrine tumors, you can have an adenocarcinoma with neuroendocrine cells. It can show pan of cell-like neuroendocrine differentiation and well-differentiated neuroendocrine tumor, and you can also have a small cell neuroendocrine carcinoma. It's very aggressive. Ki67 is near 100%. Mesenchymal tumors, we talked about stump. You can have several growth patterns: hypercellular stroma with degenerative appearing cells mixed with benign glands, a phylloides subtype with leaf-like branching. It's CD34 and PR positive, and it's a tumor of specialized prostatic stroma. Stromal sarcoma is a malignant tumor where it can have a phylloides-like growth with malignant pleomorphic stroma or fascicular growth similar to a leiomyosarcoma, and expresses CD34 and PR as well. We talked about seminal vesicle, which can have prominent lipofuscin pigment, and it can have moderate to severe cytologic atypia, but it's benign, and it stains with GATA3. Amyloidosis, which is a common benign incidental finding and not associated with systemic amyloidosis. Adenocarcinoma, always first consider secondary involvement, most commonly by prostatic acinar adenocarcinoma, because primary is very rare, but if it does happen, it often has a papillary clear cell tumor. Mixed epithelial and stromal tumors, MEST. It's a biphasic tumor with stromal and benign epithelial components. And we talked about cystadenoma, fibroadenoma, and adenosarcoma. And then mix of cancer, talked about basal cell hyperplasia, a central zone sampling, adenosis, and atrophy, including simple atrophy, postetrophic hyperplasia, partial atrophy. We talked about Cowper's glands, clear cell hyperplasia, where we have big nodules of clear cells with cribriform pattern, smooth gland borders and lobular pattern, and sclerosing adenosis, where you should have no cytologic atypia with dense spindled stroma with compressed and distorted epithelial elements. Well, thank you so much for tuning in to this episode of Pathogonia, and we'll see you on our next one.